Hi, my name is Courtney Ruff, and I'm here today with Dr. Ramesh Vapana. He's a professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at UTHealth Houston. He's also the co-director of the Fetal Center at Children's Memorial Hermann Hospital in UTHealth Houston, and the director of the Division of Fetal Intervention at UTHealth Houston and McGovern Medical School. So Dr. Vapana is taking time to speak with us about the fetoscopic laser ablation of type 2 Vasa Previa. Thank you again, Dr. Rapana, for taking the time to speak with us. And we hope that this presentation just provides great, insightful information to both referring physicians and patients that are dealing with this diagnosis. So without further ado, Dr. Rapana, the floor is yours.
Thank you, Courtney. Thank you all for joining in to listen to about Vasa Previa. First, I will talk about what is Vasa Previa. Vasa Previa is nothing but a fetal blood vessel traveling ahead of the fetal head over the cervix. And it happens around 2,000 births in the United States per year. And that type of vessels in front of the head, as the baby tries to come down through the cervix, it can rip the vessel and bleed. And it can be quite catastrophic in the sense the baby could die instantly because of loss of blood flow from the baby bleeding out. There are major two types, and there is also a third type. The type 1 is the most common, where the umbilical cord is attached over the cervix. And in that case, that would be a type 1. And if you diagnose that, we manage as a standard of care for Vasa Previa. And the type 2 is where most of the placenta is in a normal position, whereas another small piece of placenta will be on the other side of the uterine wall, and the blood vessel will travel over the cervix, becoming a Vasa Previa. Now, once you diagnose with Vasa Previa, both are managed in a standard of care similarly. So typical diagnosis happens at the time of anatomy ultrasound. The risk factors are typically there is low-lying placenta, means placenta is very low, or they can have a placental cord insertion looks abnormal, or if they have multiple pregnancies, any of that, then there'll be higher suspicion for looking for this. And the diagnosis of Vasa Previa is fairly straightforward, that do an ultrasound through vagina, and then using a color Doppler, they can pick up the flow of the fetus over the cervix. And that's the standard of diagnosis. Once it's diagnosed, the doctors will typically follow very closely to make sure the cervix is still long to stay home. But if they get shorter, they would hospitalize sooner. And when they get admitted to the hospital can vary from place to place, and comfort of the doctor and the patient. Typically around 28, 30 weeks will be hospitalized. The only reason for hospitalization is if there is an emergency like bleeding, rupture membrane, or labor, your closest proximity to the operating room for delivery. That's the only reason you're in the hospital. It doesn't really prevent you from bleeding. If it just prevents you from, if there is a bleeding, you have a close proximity for delivery. So, and the next management part on this is delivery before you go into labor, and that is typically done at 34 weeks is the optimal time for a delivery for a Vasa Previa. Now, despite this standard of care, around 1 in 5 end up emergently delivering in the hospital. So 4 out of 5 could still go controlled delivery, but 1 out of 5 may end up in an emergency delivery. With this much rigorous management, there is around 3% chance that you might still lose the baby, due to the Vasa Previa. And not to underestimate the stress and anxiety the mother goes through of having a Vasa Previa and the impending bleeding through all this process. This is the standard of care. Courtney, if have any questions before we go to our innovation methods that we have come up with?
Yeah, so again, as a patient, just making sure that understanding the timeline, again, I ask these questions because I'm a mom and have been through 3 pregnancies and haven't faced this diagnosis. But if I, were to anticipate we had patients that were anticipating a diagnosis of Vasa Previa. So the anticipation is that the diagnosis usually comes right around what is the anatomy ultrasound at around 18 to 22 weeks of gestation. And then potentially just for further management, referral to a maternal-fetal medicine specialist for that management, and then anticipated inpatient stay for that management going forward in this. Am I correct in that understanding?
You're correct. So the question is, why suspected diagnosis is 18 to 20 weeks? Why do you need to confirm at 28, 30 weeks? Approximately 1 in 3 pregnancies, the placenta tries to move upwards and everything will kind of move away from the cervix. So in that case, you don't need to worry about Vasa Previa. So that's the reason we do the second time or a little later in the pregnancy to confirm the Vasa Previa. Once it's there at 28, 30 weeks of Vasa Previa, it's unlikely to go away. And that's the reason for the second time point for examination. And also between that 12 weeks or 20 weeks to 28 weeks, the likelihood of going into labor, rupturing is pretty low. So that's the window. Yeah.
Right. Thank you. That's very helpful. Thank you.
Yeah. So the innovative method, in fact, was discovered by other researchers, the fetal surgeons, and we have essentially used the same methodology to optimize the method. And then here we are presenting our experience. In fact, the very first patient that we did was in the mid-COVID, and it feels like a long time, but in fact, it was 2020 June, middle of an upsurge of COVID in Houston. And this patient mother she had a 3-year-old at home. She was admitted to the hospital for at least 6 weeks. And that was the time everybody walked around with lunar suits. And there was no visitors in the hospital. Nobody could, move in and out. So we offered this option for the patient. If it is successful, she could go home. And I don't think she blinked an eye, and she said yes. So we have significant technical expertise in how to do this procedure in other conditions. It's a matter of translating our skill to this particular condition. So in this, once we diagnose a type 2 Vasa Previa, we cannot do this in type 1. Once it's type 2 Vasa Previa, we believe the placenta share from the Vasa Previa is very minimal. By taking out that circulation, it would not affect the baby's ongoing growth. So in those selective patients where we would put a little a cannula or like a straw into the abdomen, into the uterus, and then we put a camera in and then visualize the connection, and then we disconnect using a laser surgery. That is simple as that. So this study was conducted over a 2-year period under an IRB approval for a humanitarian device exemption, the special scopes that we have to use for this procedure. And we basically looked when we reproduce and assess the safety of this procedure. So we had 2 sets of patients. One set is a singleton pregnancy that had a type 2 Vasa Previa, and were evaluated for a potential candidacy, and they were all between 28 to 34 weeks of pregnancy. They were not in active labor, and no rupture membrane. We also had a few patients that had a TTTS undergoing laser surgery and were incidentally found to have a type 2 Vasa Previa. And they had a surgery for TTTS and also had a laser for Vasa Previa. So in general, what do we do for procedure-wise? We prepare the patient to make sure, in case we have to deliver during the procedure, the baby is optimized for lung maturity by giving steroids, 2 doses. And we do them right around 30 to 32 weeks, because if there is a risk of delivery, the baby is quite far enough in the prematurity that it's not extremely premature. And we could do this under a sedation and a local injection. Patient will be in a lithotomy position similar to a pap smear. And one patient we had to do under general anesthesia because we felt the risk of a vessel rupturing during the procedure is high due to the vessel was very large, around 10 millimeter in diameter. And then we do this in a multi-disciplinary approach with teamwork, where you have 2 sonographers helping us, looking both up and below, and then assistants to help with the scopes. And we do something called amnion infusion, where we put some fluid in to kind of see better. So when we do the procedure, once we are in there, we have to identify the vessel under scope, and we using ultrasound and direct visualization to come up, so isolate the vessel. Once we isolate the vessel, we trace it both sides to the placenta, then back to the cord, and then once we go to the placenta, this is called cartilidin, and we laser ablate the vessel to make sure it's completely sealed off. The way we know that is there is no more flow through the vessel on the ultrasound over the cervix. That is the second step. And the third step is we go across towards the placental cord insertion and we close it off again. You don't want to make sure we left anything that is open towards the cervix. So that's the two-step process to make sure we are completely sealed off the vessel. And here is a video example of one of the patient. What you're looking here is a telescopic view of inside the womb. And what you're seeing here is this big in a vessel, that is the Vasa Previa. The white thing is just an artifact from a material that can be in the amniotic fluid. And once we visualize that, we go to these Vasa Previa vessels when we just burn or laser ablate or spot weld these vessels until there is no further flow. And we have to make sure we find each of these vessels and completely stop the flow. And sometimes these vessels are large enough that they don't seal off easily. It takes quite a bit of effort to completely occlude the vessel. And when we do this, there can be a risk of rupture. And that's the reason we prepare just in case if something ruptures and bleeds, we deliver right away. So over the 2-year period, we had 13 patients were referred in for this procedure, and 6 were not eligible because 1 was not a Vasa Previa, and 5 were type 1 Vasa Previa, so we would not offer it. And then 7 were eligible for this procedure. Out of 7, 6 were successfully completed the laser, and we're going to present that outcome. 1 was a failed laser. We could not complete the laser, so the patient was delivered. So these are all the 7 patients. The diagnosis was done early on in some patients, but some were done very late in the pregnancy. That's the problem. In spite of ultrasound, sometimes they are frequently missed, and fortunately they picked up in a subsequent ultrasound. And then we did some of them. We did a 31 weeks and successful surgery. And what you see, the green line is when they went home and stayed home and then went into delivery back home. And some had a vaginal birth, as you can see, 3 of them. 3 of them had a C-section for regular obstetrical reasons, or 1 was breech baby. They had to have a C-section. So in 1 patient that had failed laser, was diagnosed late, and we intervened, but that being that far late in the pregnancy made it difficult to see everything because baby was really big. So this failed laser, again, it's important to know the technical aspects of the laser, that we ablated the vessel on one side. Despite that, as you can see here, the blood flow was continued to flow through the vessel. So we were not confident that we gotten all the flow into the vessel. This is a vein. And then the patient was delivered right away on the table. As you can see here, we could not see this tiny little vessel that was flowing into the vessel. That would have been patent if I assumed that we successfully ablated, and this could have been a risk for this baby to bleed during labor. So, and then during TTTS type 2 Vasa Previa, out of 166, 2 had a type 2 Vasa Previa, and both had among them, 1 of them had a successful laser ablation of the Vasa Previa done at 18 weeks, and she went under over 34 weeks by C-section because of breech on PPROM. There was another patient where we went to do the laser, but we abandoned the procedure for laser ablation for the Vasa Previa, but we did a laser for TTTS. This was one of the strangest placenta I have ever seen in my career. As you can see here, there are twins. 1 baby has a main land of the placenta as it is attached here, and the donor is attached really on the edge of one side of the placenta. Now, typically it should be on a single placental island, one on one side, the other one the other side. This one is attached on the very much on the corner, and then travel these vessels all the way across on the border onto a placental island on the other side. And the Vasa Previa vessels were the main vessels of the little baby. So if we had taken these vessels out, this baby certainly would have died. So we kind of, knowing that, we stopped. We did not do any more laser, left it in place, and she went on to deliver and take home 2 babies. So that just tells you how risky this procedure is, to know when not to do something. So basically, in our experience, is that fetoscopic laser surgery for type 2 Vasa is feasible and reproducible. A careful case selection and mapping are essential for success. An intraoperative transvaginal ultrasound to confirm the cessation of flow is paramount. And re-evaluate the flow in the vessels the following day and 1 week after to evaluate the success. And there is no flow, the patient can go home and deliver vaginally. And thank you.
Thank you, Dr. Papana. That was incredibly informative. We so appreciate it. Again, I like that the very last bullet point in the presentation, that a patient can deliver vaginally. Is there anything else that you feel a patient should anticipate if they were to undergo, again, the fetal intervention procedure, and then the cadence of ultrasound evaluation all the way up to the time of delivery? And is there any postpartum follow-up that they might need, or is it truly just would love your insight of what your thoughts are.
Yeah, so I think the big thing is, once we know the vessel is sealed off, especially the day after, it's pretty much, pregnancy can be treated like a singleton normal pregnancy. So they could go home, they can resume activities, including sexual activity and so on, and could go into labor whenever they go into labor. They don't need to come back. And that's what's been our experience. Of course, if there is a flow, and the reason why the doctors who are doing the procedure needs to evaluate to make sure the vessel is hard to see once there is no flow. So that's why we evaluated. We confirm once more at 1 week later, just to be sure. So far to date, we have never seen the vessels were reopened. So generally that, takes the anxiety of impending rupture, goes away. We communicate very directly with the referring physicians to explain as what was done and what can be expected in the pregnancy. And subsequent pregnancies, postpartum, there are no real risks to the mother. Like, they could go back to resuming normal activity. They can get pregnant again, whenever they would want it to. So it doesn't really change a whole lot. It kind of resumes, we kind of negated the need for C-section if they were able to have vaginal birth.
Wonderful. Wonderful. Well, thank you again. And again, thank you for anybody who's taken the time to watch this. We hope this has been an informative presentation. Again, the Fetal Center team at Children's Memorial Hermann and UTHealth Houston are happy to field any questions. Our physicians are always available. And thanks again. Thanks, Dr. Papana. Appreciate it.
Thank you. Thank you, Courtney. Bye.